No, can you hear me now? Okay. We have a few housekeeping announcements. Then we'll introduce you just back and forth. My name, and I'll have each of us introduce ourselves. My name is John Smith. I am a semi-retired surgeon from Wichita, Kansas, involved in resident teaching, IRB, skills lab, things like that. And
Sean Okatari, chair of surgery at Prisma Health in Greenville, South Carolina.
we have a few. I'm sorry. I have to have the red dot on. My mistake. Welcome to the half day. Please join us for the Thomas Orr lecture on subtotal cholecystectomy and the ACS sessions. After those sessions, please enjoy the afternoon. All scientific sessions are being streamed and recorded. Recordings will be available up to 90 days after the meeting. So if you happen to miss something, you can pick it up there. Claiming CME and self-assessment credits by May 19th. You can claim the CME in the meeting app or by email. We're pronounced the Southwestern Surgical Congress can accept tax deductible donations. Funds will be used to support educational and research initiatives. And you may donate directly through the meeting app or stop by the registration desk. We encourage all of the attendees to visit our industry sponsors during the breaks and the exhibit hall hours. And the Southwestern Surgical Congress wishes to especially recognize and thank our gold sponsor, Legally Mine.
All right. With that, we just want to remind all the speakers they have 5 minutes for their presentation and 3 minutes for the Q&A. And out of respect for all the speakers and the next session, we need to stay on time. The first paper up is impact of methocarbamol on opioid use after primary ventral and inguinal hernia repair, and will be presented by Dr. Crozier.
Okay. All right. Sounds good. Okay, good morning. My name is Caitlin Crozier. I'm a fourth-year general surgery resident at Prisma Health Upstate in Greenville, South Carolina. And as we said, I'm presenting a project on the impact of Robaxin on opioid prescribing following hernia repair. Sorry, I'm pushing it, but it's not going. Oh, you got it. Just push harder. Okay, gotcha. I personally have no disclosures. If you attending on my project, I have the listed disclosures. So really this project is brought on by the opioid epidemic and pushes to decrease opioid prescribing. This opioid epidemic really began in the 1990s with more liberal opioid prescribing. And since then, many efforts have been put in place to decrease prescribing. We've seen an up to 40% decrease in the amount of opioids written for between 2011 and 2020. But larger studies recently have shown that we are still overprescribing. As many as 90% of patients still have excess opioids following an operation, and many people don't know how to appropriately dispose of these. On the other hand, we're also seeing that up to 7% of patients are still using opioids at a year postoperatively, indicating chronic use of opioids after surgery. So in light of these things, there has been much push recently to use multimodal pain control regimens instead of just opioids following operations. So at our institution in the past 8 years, we've had a significant push to discover other ways to control pain following surgery, such as tap blocks for ventral hernia repairs, implementation of an ERAS protocol using other medications such as ibuprofen, Tylenol, gabapentin, and standardizing protocols so that we have a defined amount of opioids that will be written for certain operations. Her findings have been supported at a national level by finding similar findings in the ACHQC database. Up to 50 or 60% of patients following inguinal and ventral hernia repair don't use any opioids that they're prescribed. We've also added Robaxin to our protocol in 2020, which is what our project today is about. We've begun a pilot study to look at the impact of Robaxin on our prescribing. The project I'll be talking about today, again, is to determine the impact of Robaxin on opioid prescribing following ventral and inguinal hernia repairs. Robaxin is a centrally acting skeletal muscle relaxant that is less sedating than other muscle relaxants, such as benzodiazepines. They have been used with good anecdotal results in our institution and in literature in orthopedic surgery and breast surgery, but there is currently no literature supporting its use following ventral hernia repair or even in general surgery. Our primary endpoints of the study was to evaluate the total MME prescribed and the need for opioid refill or rescue opioid prescriptions when we implemented our protocol. So our study was a retrospective review. We looked at all patients undergoing ventral and inguinal hernia repair between July 2020 and July 2022 at our institution. Our data was prospectively collected in the ACHQC database, which looks at postoperative hernia care. We also obtained some opioid and ibuprofen and Tylenol prescribing information from Epic. Since our study was done retrospectively, we performed a 2-to-1 propensity matching using the nearest neighbor method to assess certain variables such as gender, myofascial release, wound class, things like that to try and create a control population. Our study showed that up to 44% of patients were not using opioids following ventral hernia repair versus 10% of patients in the control group. So even those that did require opioids were prescribed a significant less amount. So they were prescribed 20 MME versus 50 MME. And for reference, 20 MME is just 4 50 milligram tramadol, so much less medication. We also found that there was no difference in need for refill or rescue prescriptions. Following inguinal hernia repair, we also found that there was a decrease in opioid prescribing when people were given Robaxin. So only 67% of patients in the Robaxin receiving group were written for opioids versus 88%. Again, we saw a decrease in the amount of MME prescribed for. There was a slight increase in refills and no difference in the need for rescue opioid prescriptions. So in conclusion, our study shows that it is pretty reasonable to perform ventral and inguinal hernia repairs without prescribing opioids. There was no significant difference in the amount of rescue prescription for each group, indicating that there was not a significant amount of patients with uncontrolled pain. Of course, our study has limitations. Selection bias, we performed a retrospective review, so we cannot control for which patients were written for more opioids or opioids in general, and patient counseling as well. We always discuss with our patients preoperatively our expectations and our goal to achieve 0 opioids. But in terms of patient counseling, there was no standardized protocol. And of course, we don't have patient-reported utilization or outcomes, which would be the true marker of whether or not patients had adequate pain control and quality of life. In this, since we have a pilot study, like I mentioned, that will be a prospective randomized study that looks at Robaxin being added to our standard protocol, and that will have patient-reported outcomes. So in conclusion, again, we found that an opioid-free postoperative course is feasible following ventral and inguinal hernia repair, and that based on previous studies, Robaxin may not even be necessary, but we would need patient-reported data to make this final conclusion. Thank you to everyone who helped me on this project. And that's all.
Paper is open for questions. Who does the prescribing? Was this the prescriptions? Was this by the resident?
Usually it
attending?
would be by the resident. We did not look into that.
Okay, because I was just wondering if somebody's into the Robaxin mind camp, if you're in that camp, and if you get a prescription for Robaxin, would you intuitively give less narcotic?
Probably so.
Okay,
Yes.
thank you very much.
This is probably like a good real life example of implementing protocols over time.
Yeah.
Working.
Thank you so much.
Okay. Second. Number 11, not all cholecystitis is created. And forgetful again.
It's all right.
That's, keep me honest.
Okay.
Not all cholecystitis is created equal. Disparities contributing to presentation and failure of outpatient algorithm, presented by Dr. Taylor Martin.
Good morning, I'm Taylor Martin from the University of Oklahoma. Thank you for the opportunity to present this morning. Me and my partners do not have any disclosures on this project. Overall, our previous publication revealed that patients presenting to the ED with cholelithiasis and right upper quadrant pain, that pain greater than 4 hours was a superior predictor of cholecystitis than ultrasound. And when an ED diagnosis was strictly radiologic, cholecystitis is missed. Literature, we know that there's a 20% failure rate between ED to outpatient clinic cholecystectomy, and this is in an insured and Medicare population. We know that lower socioeconomic status, the uninsured and racial minorities are more likely to come to the ED. They're more likely to have complex biliary diseases, worse outcomes, and increased mortality. So we aim to identify the social and demographic factors that contribute to these patient presentations and completion of these pathways. And we hypothesize that the racial minority, poverty, and uninsured would be associated with an increased ED utilization, and that these patients would be vulnerable to fail this pathway. We conducted a single study, a single institution retrospective review of 1,240 patients over a timeframe of 4 years who underwent cholecystectomy for symptomatic cholelithiasis and cholecystitis alone. All other reasons for cholecystectomy was excluded. We identified 2 patient populations within our institution, one in the clinic with 299 patients and one in the emergency department with 308. Clinical presentation and intraoperative findings were collected and ultimately compared to final surgical pathology. Within our social demographics, we collected race, insurance status, and the billing zip code, and we utilized the Zip Atlas zip code tables to correspond to those zip codes to billing poverty levels and median household income. Our clinical results were similar in that if you had acute cholecystitis, you were more likely to come to the ED, you were more likely to report 4 hours of pain. But ideally, ultrasound only identified 30% of these and 12% of clinic patients with cholecystitis on final surgical pathology. When looking at the social demographics, in the ED, only 46% were Caucasian and 44% were more likely to report other as race, compared to a clinic population of Oklahoma of 78% Caucasian. For an insurance status, only 1/3 of our patients had insurance, compared to 90% in the clinic. And with zip code poverty levels, if you were coming to the ED, you were more likely to have a poverty level greater than 10% at 74% of this population versus the 57% of clinic patients were less than 10% poverty zip code. Ultimately, as poverty levels rose, the insurance status decreased. And as you can see, with the zip code poverty greater than 20%, only 32.5% of these patients were insured. We conducted a logistic regression to assess the variable relationships between the ED and clinic patients and found an odds ratio of 13.1 for non-insurance to present to the emergency department and 15.6 if you were to have right upper quadrant pain greater than 4 hours. Interestingly, no one race was identified with an increased odds ratio, but when comparing Caucasian to non-Caucasian, we did find a statistical difference. And this was represented, the minorities were disproportionately overrepresented within our population as they represent 20% of our state population, but 54% of those that presented to the ED. Ultimately, insurance status in our regression analysis was found to be the most associated with ED utilization. And we propose that these patients self-select into the algorithms based off symptomatology, social factors, and insurance status combined. And that special consideration should be taken for insurance status to perform intervention at index and counter. We did find a disparity, and ultimately we believe these patients are set up to fail with misdiagnosis and discharge with potentially the inability to follow up. And we believe that this likely contributes to the well-documented delay in diagnosis and worse outcomes in this population. So what can we do? We would recommend that we treat the patient and their symptoms, and that cholecystectomy should be offered upon the clinical diagnosis of cholecystitis with pain greater than 4 hours at their index ED presentation. Briefly, our limitations, it's a retrospective study at a single institution, and there is some selection bias in that not all patients that had right upper quadrant pain were identified, and only those that underwent cholecystectomy. Future research, we'd like to have the prospective study to kind of evaluate whether or not this index encounter would improve access to care, outcomes, or its cost effectiveness, or could we also do this with an after-hours emergency general surgery clinic? Questions?
So raise your hand if you have a copy of Cope's diagnosis of the acute abdomen. Yeah, it's becoming a lost art. Congratulations. It could be that your institution is the last to really do a good physical examination because we go right to the imaging. So I can't tell if you guys are just astute clinicians or your ultrasonographers are really bad because.
So I think I'll kind of teeter on this one. So ultimately, when our first paper, when we talked about ultrasound positivity, instead of going off of like specifically just that one statement of the impression that says blah, 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 clinically correlate, we looked at 3 factors. So wall thickness, pericholecystic fluid, and whether or not they had a positive sonographic Murphy's. If 2 of the 3 were positive, we considered the ultrasound positive, even if the radiologist read symptomatic cholecystectomy. So we really tried to keep it pretty objective in whether or not going off of criteria and not a subjective interpretation.
And I might have missed it, your conversion to open rate.
So the majority of, I listed just briefly, we looked at laparoscopic and both, they were not statistically significant. We had a little bit more of the robotic minimally invasive in the outpatient clinic, but most of our procedures were able to stay laparoscopic within both populations.
And then you may have to phone a friend for this, but are you a safety net hospital? I mean, like I agree with your philosophy, just take care of the patient. We'll figure out the finances on the back end, but on the back end, it's often uninsured or underinsured. That's just bad debt, and you don't collect that.
Yes, that OU is that institution for our state, and oftentimes I think when we started this project, we saw that people would be getting discharged from an emergency department after presenting, and they're like, "You should just go to OU." And that's how we capture a lot of our patients.
Do you have the problem as with the emergency department that has done everything before they even call the surgery team?
Sometimes I think our residents would kind of echo the thought that it's sometimes all or nothing. So sometimes we get a call when a patient just shows up to the ER, and sometimes we're involved after they've performed an ultrasound or a CT. But through this project over the last several years, we've actually partnered and kind of made a streamlined protocol for the emergency department so that they will usually give us a call or a heads up if someone has right upper quadrant pain, and we're trying to capture these, even if their red is cholecystectomy, offer the patient surgery.
Any other questions? Great job.
Thank you.
Our next paper is Advancing Geriatric Surgical Outcomes and Elective Ventral Hernia Repair Surgeries, an American College of Surgeons National Surgical Quality Improvement Program study. And I believe is going to be presented by Ms. Francis?
Yes.
No.
Hi. Hello, my name is Alyssa Greenwood Francis, and I'm a fourth-year medical student at Texas Tech El Paso. Thank you to the Southwestern Surgical Congress for having us here today to present our research. Let's see. I have nothing to disclose. So adults age 65 and older are the largest and fastest growing age cohort in the United States and are projected to account for 1/5 of the entire population in the next few decades. There's a known correlation with older age and an increase in both postoperative morbidity and mortality in surgery, and older adults are at a particularly increased risk for developing ventral and incisional hernias due to age-related risk factors, including weak anterior abdominal wall musculature and reduced tissue regeneration. Additionally, older adults undergoing hernia repair are more likely to have multiple comorbidities, a history of prior abdominal surgeries, higher frailty index, and lower functional status. Ventral hernias are a common pathology with a 25% lifetime risk, and incisional hernias, which often develop post-laparotomy, carry 11 to 50% lifetime prevalence. Current literature recommends elective repair of asymptomatic hernias in adults older than 65 years due to increased risk for obstruction or incarceration. However, there's limited data characterizing the postoperative complications faced by older adults undergoing elective hernia repair, particularly in examining differences within the older adult cohort. For example, comparing patients 65 to 74 years to those greater than or equal to 75 years. The stratification of older adults into multiple age groups is important since patients older than 75 years are known to be especially vulnerable due to increased frailty and multimorbidity. The goal of our study was to determine if an increase in age correlates to differences in surgical outcomes for elective ventral or incisional hernia repairs by analyzing 30-day perioperative outcomes. We performed a retrospective cohort study using the ACS NISPUT database for years 2016 to 2020. We were looking at all the diagnosis codes for laparoscopic or open repair, for incisional or ventral hernias with or without mesh, and we stratified the group into three different age groups. We were interested in comparing the older adult cohort, typically classified as 65 years and older, to each other. So we had one group that was 65 to 74 years, and then one group 75 years or older. And we were comparing both of these groups to adults aged less than 64 years. The goal of our study was to determine if there was a difference in 30-day perioperative outcomes. So we looked at complication, readmission, reoperation rates, hospital length of stay, and we analyzed these using bivariate chi-squared and multivariate logistic regression. We found 116,643 patients that had elective ventral or incisional hernia repair. About 70% of those were 18 to 64 years, 21% 65 to 74, and 9% were age 75 years and older. Looking at the univariate logistic regression, we see that for several 30-day perioperative complications, there are increasing odds with increasing age. So highlighted on the right side of the table, we can see that older adults in the greater than 75-year age group are significantly more likely to have any complication, any readmission related to the surgery, reoperation, extended length of stay, compared to adults age 65 to 74 years and adults age 64 years and younger. When we controlled for these same 30-day perioperative complications in our multivariate analysis, we saw a similar pattern compared to 18 to 64 years, the 1864-year age group. Patients aged greater than or equal to 75 years were 32% more likely to have any complication, 37% more likely to be readmitted for any reason, 30% more likely to be readmitted for a reason related to the hernia operation, 67% more likely to have an extended length of stay, and 29% more likely to require a reoperation. So our patients aged 75 years and older had significantly higher rates of overall complications, higher rates of total and hernia-related readmissions, more likely to have an extended hospital length of stay, and higher reoperation rate compared to younger patients. As the population ages, the incidence of ventral and incisional hernias will continue to rise, and our further stratification of older adults into two groups is important, given the high prevalence of ventral hernias in patients aged 75 years and older, which was nearly 10% in our cohort, and the need to preoperatively address age-related risk factors in this population. Looking into the future, we need to prioritize dedicated research for age stratified adult populations, focus on tailored perioperative care, and develop multidisciplinary care teams for older adults. Particularly, we should continue to emphasize the greater than 65-year age cohort as a heterogeneous group of patients who require increasingly focused and thoughtful care with increasing age. I'd like to acknowledge the following for their support of this project, and thank you all.
Very nicely presented. I'd be curious, when do you, what we can't tell from NSQIP is the frailty index. So you present with a hernia, the surgeon, he or she looked at it, eyeballed the patient, looked at the chart and said, weighed the risks and benefits and said, let's go fix it. This, I think, is helpful information to say we can fix it, but you're still at increased risk of complications to a younger cohort. When do you need to say, let's just keep an eye on this? When do you just say watchful waiting and let's roll the dice?
Right. And of course, that would be very patient specific. The frailty index is something that we talk about. We don't use it very much clinically, but it is something we discuss in our paper because the modified frailty index is something that has been used a little bit more in the literature. And I think most of the things that are included in there, we included comorbidities and looked at in our data in the expanded paper. And mostly the adults over 75 also fit that frailty index. So you could theoretically go through and do that clinically and figure out if they're very frail or not. However, even if you say, okay, this patient is very frail on paper, it depends also clinically on their picture if they really need the operation or not.
All right. I noticed another talk on the laparoscopic bilateral inguinal hernia repair on a 100-year-old patient. That didn't come from your analysis, did it?
No.
Okay, that was
No.
somewhere between 100 is when you stop and say watchful waiting. I thought, okay.
They're very healthy.
Anybody, any other questions? Thank you so much.
Thank you.
Next presentation. Next. A retrospective cohort study comparing readmission rates among surgical patients seen in the office versus evaluated via telemedicine, presented by Dr. Lombardi.
Thank you. Hi, my name is Nick Lombardi. I'm from PGY4 at Allegheny General Hospital. Thanks for having me here today. I'll be presenting a study we did, a single institution retrospective cohort study that was looking at readmission rates among surgical patients. So as we all know, during the COVID-19 pandemic, there had to be a drastic change in protocols to try and reduce face-to-face interaction and therefore reduce the risk of transmission. And as a result, a lot of in-office, in-person visits were changed to kind of remote visits to reduce interactions. And there have been several studies investigating this. A lot of them focus on either elective outpatient operations or a small subset of kind of low risk patients. And the results are encouraging. Patients are satisfied with this type of follow-up. The compliance is very good and it saves time and cost for both the patient and the provider. In particular, the patient doesn't have to take as much time off work to get to an appointment, saves time on travel. And the time that they have to dedicate to a clinic appointment is less than they would if they had to come in office. But the question remains, is it a safe modality to follow up these patients? So to address this question, or address this concern, we asked the following question: among patients and seen by the acute care surgery team inpatient, was there a difference in readmission rates between patients seen in office and those seen via telemedicine? Again, it was a retrospective review. Our study period was from October 2019 to March of 2021, and March of 2020, there was a shift in our protocols, and our outpatient visits were switched to exclusively telehealth. So patients before that time were in the in-office group, and after that time were in the telehealth group. And our primary outcome was readmission within 30 days. We did stratify our patients into low, medium, and high complexity groups, just because, as we all know, in the acute care surgery realm, there's a lot of different types of patients. And this is what we found. These are our demographics. As you can see, we had over 600 patients, about 55% were seen via telemedicine. There were differences between the groups. The telemedicine patients were younger, had shorter length of stay, were more likely to be discharged home, and were more likely to be in the low complexity group. Of notes, there was a similar amount of patients in the high complexity group. When stratifying readmission rates simply by complexity, you can see that the odds of being readmitted go up as your complexity goes up, which is not surprising. We further stratified readmission rates based on whether they were seen in an office or via telemedicine. And as you can see, regardless of the complexity of the patient, there was no difference in rate of readmission, whether you were seen in office or you were seen via telemedicine. So none of these differences here were statistically significant. And in fact, the trend was towards you maybe being more likely readmitted if you were seen in office. Clearly, our study has limitations. It's retrospective in nature, and as a result, there's differences between the groups. Additionally, there's going to be an unknown number of patients lost to follow-up. These include patients we saw in the hospital and recommended follow-up, and then they never saw us in the office, but also patients potentially who readmitted to another hospital, we didn't know about it. The way our hospital system works, we have over 10 hospitals, more like 14 now, that typically we get our patients referred back to Allegheny General Hospital. But again, of course, there's going to be patients who we lose because it's a retrospective study. There's several strengths. We had broad inclusion criteria. Essentially, no one was excluded from this study, which allowed us to, which makes the study applicable to most acute care surgery practices. And we had a relatively large sample size. So in conclusion, we concluded that telehealth can be utilized safely in a diverse group of acute care surgery patients, including those that are very complex, without concern for an increase in readmission rates. Thank you, guys. I'll take any questions.
Go ahead.
I have a first question. How do you compensate for what the patient might have not told you on the telemedicine?
It's a good question. So the way that the telemedicine was performed, it was mostly phone calls, which made it very applicable because everyone has a phone and more people have a phone and can use it than have access to kind of a video system, which did break down some barriers and make it easier for everyone to participate. If there was a wound involved or something we need to look at, pictures were taken and uploaded to Epic, or occasionally or securely emailed to our clinic. And we do have several wounds that were followed over a long period of time via pictures in the charts, and that we were able to watch improvement. So certainly if the patient doesn't report it, we don't know about it. That's obviously a concern. But if there's something we wanted to look at, we could have them send us a picture.
So these were initial visits done by telemedicine, and you said, yep, let's do surgery. And then they showed up for surgery.
So I didn't explain it well enough. These were patients we saw in the hospital and then recommended they follow up. So we saw in the hospital and either took out their appendix, took out their gallbladder, treated their necrotizing pancreatitis, discharged them, said follow us up in the clinic, and then they came back. So as opposed to new patient index visits, these were follow-up hospital visits.
Okay, so it was the post-op that you did
Correct.
Telemedicine follow-up with.
Yes,
I
absolutely.
see. Okay.
Yeah, sorry about that.
Yeah, all right. And then are you still doing this?
Yeah, so about 70 to 75% of our post-op or post-scene, if we didn't operate on them, are via telemedicine. Now
That by choice, you offer them
Yep.
telemedicine or in person and they say tele.
Yeah.
Which means they don't want to fight the parking, or they live 100 miles away.
Yep, exactly. Since we do have everyone has this kind of a large area around their hospital that they take care of. It can be very far away for patients, and no one wants to drive into the city. They tell us that all the time, and so they do prefer this.
The follow-up on this would be to look at distance traveled, if that impacted it, because like you said, you don't know if they got readmitted somewhere else
Absolutely.
and didn't want to drive back to the index location.
For sure. And data I didn't show was the distance distance from their house to the hospital was not different between the two groups. I don't have the exact mileage off the top of my head, but the distance from the hospital were the same in both groups. But certainly that is an area of interest. Thank you.
Thank you so much. Right, and our next paper is entitled, Can a Hiatal Hernia Repair Cure Anemia? And this will be presented by Dr. Juarez.
Good morning. My name is Selena Juarez. I am a PGY5 at Prisma Health, and thank you for being here this morning to listen to my talk, Can a Hiatal Hernia Repair Cure Anemia? I personally do not have any disclosures. However, here are a list of the disclosures the other authors have. So it has been recognized that there is an association between paraesophageal hernias and anemia. The prevalence of iron deficiency anemia in patients with large paraesophageal hernias has been reported anywhere from 6 to 37%. It is also known that Cameron lesions are a source of anemia in these patients with paraesophageal hernias. However, they're only found in about 29 to 42% of patients who are anemic and have a paraesophageal hernia. Because of this, we decided to conduct a study to evaluate the resolution of anemia in patients undergoing paraesophageal, regardless of whether a Cameron lesion was present, because they can often be missed or potentially underreported. We conducted a single institute retrospective chart review of patients who had undergone hernia August 1st, 2006 and December 31st, 2021. Anemia was defined in women as a hemoglobin less than 12.1 grams per deciliter, and in males as a hemoglobin less than 13.1 grams per deciliter. The inclusion of patients into the group of Cameron ulcers was based on ICD codes from EGDs that were present in our electronic medical record. And statistical analysis was performed of preoperative and postoperative hemoglobins at 3, 6, 12, 18, and 24 months postoperatively. We were able to identify 289 patients who had preoperative anemia and or Cameron ulcers, but only 125 of these patients had preoperative and postoperative hemoglobins that were available for analysis. Here's a summary of our demographics and comorbidities of our patient. The majority of our patients were relatively healthy, elderly Caucasian women, and there was not a significant outlier on comorbidities. We performed a comparison of preoperative and postoperative hemoglobins over 3, 6, 12, 18, and 24 months postoperatively. There was a statistical significance in the resolution of anemia of patients undergoing hiatal hernia repair at 6 months, and this held true up to 2 years of our follow-up, which was for a total of 81 patients out of 125. That gives us about a 65% rate. However, only 3 months after surgery was the only interval where all of our patients had a postoperative hemoglobin. So we performed a McNewer's test in order to analyze the preoperative and postoperative hemoglobin within each subject. And we were able to show that at 6 months and up to 24 months postoperatively, there was a statistical significance in the resolution of anemia following paraesophageal hernia repair within each subject. Our study demonstrated that there is a resolution of anemia in patients with preoperative anemia and or Cameron ulcers up at the 6-month mark postoperatively from a paraesophageal hernia repair. This remained true for up to 2 years follow-up. Our rate of normalization at the 2-year mark was about 65%, which is consistent with prior reports in the literature of 60 to 91%. This is also much higher than the rate of resolution of anemia for medical management alone, which is quoted at about 35%. Our study is limited by its retrospective nature. It relied on having an appropriate ICD code, which was often entered by referring physicians. Intrinsically, because of this, we may not have identified all of our patients at our institution that met criteria. And since anemia, resolution of anemia is not a primary end goal after paraesophageal hernia repair, not all patients who underwent hernia repair had a preoperative and postoperative hemoglobin available for analysis. We also did not track our postoperative use of PPIs. However, our practice is to stop those after therapy, after hernia repair. Because the workup of anemia usually includes an EGD and a colonoscopy as patients are being evaluated for malignancy, it has been proposed in the literature that in the setting of chronic anemia and the presence of a paraesophageal hernia, the patient should have a referral to a surgeon to discuss hernia repair if no other identifiable source is found. Moving forward, we ideally would like to perform a prospective multi-center study that further evaluates the risk and benefits of early minimally invasive hiatal hernia repair. I would like to thank all of my attendings who helped me with this project, and Grace Wellenborn, Dawn Blackhurst, and our wonderful medical students, Erica and Leah. Thank you.
So you included patients that had documented Cameron's ulcers, but also just anemia, but without a necessarily a known ulcer.
Yes, sir.
Did you break those two groups out just to see how they did?
No, we did not. We did not break them down. We just included them all within the 125.
Because it makes sense to me that if you have a Cameron ulcer and you do surgery, that's the one thing that'll make it
Heal.
heal.
Mhm.
And then you would hope that the anemia would get better. But to have just anemia of unknown origin
Mhm.
and no Cameron ulcer,
Mhm.
and then the hemoglobin got better, there's 1,000 different things that could cause that anemia. You weren't really blaming it on the ulcer then in that situation.
No, you weren't. And there is a paper that was done by Dr. Louis at Swedish, and he was able to show that anemia alone plus anemia with a Cameron ulcer, there was resolution of anemia in both groups, but there was a higher rate of resolution in that anemia if the patient had a Cameron.
And then do you have any post-op endoscopy surveillance, which isn't done very often, to show
Yeah.
healing of the ulcer, and that group also, that person's anemia actually got better?
Unfortunately not. We did not have any because a lot of the EGDs performed were by the referring gastroenterologist. We didn't do our own preoperative EGDs, so we didn't follow up.
And I'm doing a lot of these in my own personal practice. So what do I tell my patients now about the anemia? Like, if it's going to get better, it's going to get better at
6 months.
6 months. So if it's not better by 6 months, my surgery didn't fix the anemia. That's
Possibly.
Possibly. Okay.
Thank you.
Thank you very much.
Next paper. Impact of. I haven't learned this yet. I haven't had enough trips through the maze. Next paper, impact of liposomal bupivacaine tap blocks on patient outcomes in minimally invasive colorectal surgery. Presented by Dr. Spielman.
We have Mr. Spielman. Someone need to check the lobby bar.
Shall we take the next paper?
Yeah, I think we'll proceed just in case they show up. We'll see if we have the luxury of time to get them back on the schedule. Otherwise, we're definitely going to make enough time for you to make your pilgrimage to the farmhouse. Okay.
Pilgrimage, huh?
All right, we'll go on to, I believe the next one then is Quickshot 16, disparities in outpatient rural cholecystectomy outcomes. All right. And to be presented by Dr. Howell.
Thank you. The authors have no conflicts of interest to report, but this project was made possible by a CTSI research voucher at Harbor UCLA. Rural surgeons and the care they provide is a critical resource to local communities. Rural populations have social and geographical isolation that results in significant time and resources to access healthcare. There are numerous challenges facing rural surgery, including workforce shortages and a narrow profit margin that relies on both surgeons and patient volume for financial viability. When patients bypass their local hospital to receive care at another facility, this places a valuable local resource under significant financial stress and risk of closure. A recent study that looked at longitudinal and elective operations for outpatient surgeries noted that there were the highest rates of bypass for operations with the greatest risk of blood loss and postoperative complications. Although cholecystectomy had the lowest rate of bypass, more than 50% of patients still bypass their local hospital. This behavior is concerning, and some authors have postulated that it is due to perceptions of poor outcomes that patients have bypassed their rural hospitals. We aimed to characterize the differences in elective cholecystectomy outcomes between rural and urban hospitals with the hypothesis that rural hospitals had similar outcomes to urban hospitals. We did a retrospective cohort analysis using the National Ambulatory Surgery Sample. NASS is part of the Healthcare Cost and Utilization Project, which is the largest collection of longitudinal databases in the United States. NASS is an ambulatory surgery database that provides national estimates of outpatient major ambulatory encounters at hospital-owned facilities. ICD-10 codes were used to identify patients undergoing cholecystectomy who are 20 years or older between 2016 and 2018. Demographics, comorbidities, indication for operation, and hospital data were collected. Rural and urban were defined using the core-based statistical area codes from the 2010 census. Urban areas were metropolitan with more than 50,000 people, whereas rural included micropolitan with 10,000 to 50,000 people and non-core areas with less than 10,000. The primary outcomes analyzed were a surgical approach, laparoscopic or open, complications including infectious, cardiac, pulmonary, and renal, and patient disposition, such as routine discharge, transfer to a short-term hospital, admission to rehab, or mortality. We did a bivariable analysis looking at demographic, hospital, and outcome differences between the rural and urban hospitals. This was followed by a multivariable regression analysis to confirm these differences for potentially confounding variables. Our model adjusted for demographics, comorbidities as measured by the Elix-Hauser comorbidity measure, indication for operation, and hospital factors. Overall, patients were predominantly female in both rural and urban hospitals, but there were slightly fewer comorbidities at the rural hospitals as seen by the lower Elix-Hauser comorbidity measure. Although there were some differences in insurance status between rural and urban patients, a notable trend is that over 85% of rural patients were in the lowest two quartiles for median household income, whereas over 50% of urban patients were in the top two quartiles. In both rural and urban hospitals, cholecystitis was the most common indication for operation, but this is potentially secondary to coding and billing practices influencing patient charting. The majority of urban hospitals were teaching, but due to the rarity of rural hospitals that were teaching status, rural hospitals were not further subdivided into teaching and non-teaching. Small hospitals were more common in the rural setting, whereas large hospitals were more common in urbans. On our bivariable analysis where urban hospitals were used as the reference, there was no difference in laparoscopy, but there were higher rates of complications in rural hospitals. This trend did hold true on our multivariable regression analysis. While doing our bivariable analysis for patient disposition, there were higher rates of transfer to short-term hospitals and other facilities at the rural hospitals. Short-term hospitals were transferred to another acute care hospital or admission at the same hospital where the ambulatory encounter occurred. Other facilities included SNFs, intermediate care facilities, and rehab. On multivariable analysis, the transfer to short-term hospitals was still more common in the rural hospitals, but there were no differences in routine discharge or mortality. The very wide confidence interval for mortalities is due to the fact that there were very few mortalities at both rural and urban hospitals. And so rural patients did have a lower median household income and fewer comorbidities. They did have a higher transfer rate to short-term hospitals and complications. Ongoing research is needed to explore the social determinants of health impacting rural populations, investigate the differences in complications and transfer rates so that adequate resources may be allocated to bridge disparities and support rural surgery. Thank you.
Nicely presented. It was interesting, choledocholithiasis wasn't different because you would think that's usually either no ERCPist, no comfort with laparoscopic transcystic common bile duct exploration, but it was no different.
They were very rare in both. And I think it's because it's an outpatient, and for cholangitis, we only had 3 in the weighted sample. So I think that was part of it.
And the patients that did have to get the transfer, were those the patients with the complications?
We're still working on trying to figure that out. The suspicion is yes, because so many of our patients in the rural setting that were considered open ended up admitted and transferred. So we believe yes, but we're still working on that.
And, you know, I grew up in a town of 3,000 people, so my definition of rural might be different than UCLA's. What's your definition of?
I would go by what we did with our analysis with the micropolitan of 10,000 to 50,000 people or less than 10,000 people.
All right, that's a pretty big city to me, but that's okay. All right, any other questions? Thank you so much.
Thank you.
Got the microphone this time. Next paper, accuracy of MRI in staging of early rectal cancer. Presenter, Dr. Winos. Winos.
All right. My name is Chelsea Wanos. I'm one of the 30 residents from the University of Nebraska Medical Center. I just want to thank you guys for the opportunity to speak here today. Okay. So colorectal cancer remains the 3rd most common and leading cause of cancer-related deaths here in the United States, with an estimated 46,000 new cases of colorectal cancer to be diagnosed, of rectal cancer to be diagnosed this year alone. While incidence and mortality have been on the decline in recent years, with increased adherence and access to screening, accurate diagnosis in those patients with rectal cancer has a significant impact on management. According to the most recent NCCN guidelines, rectal tumors invading through the muscularis propria into adjacent tissues are classified as T3, and neoadjuvant chemoradiation, as opposed to upfront surgery, is the recommended therapy. Currently, magnetic resonance imaging serves as the optimal staging modality in rectal cancer. However, MRI's limited ability to determine tumor depth of invasion can lead to misstaging in certain patients. The purpose of this study was to evaluate the accuracy of MRI in the staging of early rectal cancer. Specifically, we looked at T1 and T2 tumors by comparing preoperative staging to findings on final pathology. So the American College of Surgeons National Surgical Quality Improvement Program proctectomy targeted database was used to identify all patients who were diagnosed with either clinical T1N0 or clinical T2N0 disease who underwent proctectomy with curative intent. Patients who received a neoadjuvant chemoradiation or had metastatic disease were excluded from the study. Demographic, preoperative, including clinical staging, operative, and pathologic staging were all collected. So these are some of our results. A total of 730 patients were included with a median age of 66 years, 59.3% of whom were male, 61.9% Caucasian. Of these, 21.5% of patients were classified as T1N0, so that was a total of 157 patients, while 78.5% were classified as clinical T2N0. For those patients with clinical T1N0 disease on preoperative imaging, final pathology was T0N0 for 20.4% of patients. That's for the T0 and in situ groups there. T1N0 for 41.4% of patients, T2N0 or 1 for 21% of patients, and T3 to 4 and 0 to 1 for 14.6% of patients. MRI was associated with a higher specificity of 83.4% with respect to diagnosing clinical T1 disease on final pathology. However, a total of 14.6% of patients were still ultimately diagnosed with T3 or greater disease, and 6.3% with nodal disease. For those patients with clinical T2N0 disease, final pathology was T0N0 for 6.6% of patients, T1N0 for 16.6% of patients, T2N0 for 45.9%, and T3 to 4 for 30.1% of patients. So MRI was clearly far less specific with a specificity of 28.6% with respect to diagnosing T2 disease, with 30.1% of patients ultimately being diagnosed with T3 or greater disease, and 8% with nodal disease. So some conclusions. This study found MRI to have a decreased specificity in diagnosing more advanced rectal tumors. And when I say that, I'm referring to T2 tumors compared to early T1 lesions with a tendency to understage in this selected cohort, with up to a third of T2 patients ultimately being diagnosed with T3 or greater disease on final pathology. These findings are are somewhat at odds with anecdotal experiences at our own institution, as well as, previous studies in the literature that demonstrated a tendency to overstage these tumors. However, as one of my colleagues presented yesterday, the greatest predictive factor for a pathologic complete response following neoadjuvant chemoradiation for rectal cancer is the accurate preoperative nodal staging. So this study clearly demonstrates that MRI, captures this regardless of T stage, with less than 10% of patients ultimately being diagnosed with nodal disease on final pathology. Thank you.
I'm trying to wrap my head around this now. So how many of these got rectal ultrasound for staging?
So these were all MRI.
They didn't.
No.
So it was like, there's no way to compare the rectal ultrasound to the MRI.
Yeah.
And then you have to decide which one's the gold standard and which one is the comparative group.
Yeah, so looking through the literature, endorectal ultrasound is more sensitive in diagnosing the early tumors T1 or 2, but there doesn't really seem to be a great or a perfect modality to capture those T2 or early T3 tumors, and MRI is really the best that we have at this time.
And so would you say MRI is better for the nodes then?
Yes.
For sure.
So- So if you're worried about not capturing those patients who need neoadjuvant therapy, I think MRI will certainly do that. But if it's just based off of tumor in patients who don't have nodal disease,
And then,
it's kind of a tough group
Yeah.
to diagnose.
And I can understand MRI calling it T1 and it really came back T2 or T2, it came back T3 or T2, it came back T1. But how many skipped a stage? Like it was T1 and the path came back T3 and vice versa.
I mean, I did have that on our slides
Congress.
there. It was, so I can go back.
Not off by one stage, but off by 2.
Yeah, it was not very many. Let me see for clinical T1 patients who were ultimately on final pathology diagnosed with T3, that was 14.6%. So not insignificant.
So is this going to change Dr. Langeveld's practice at all?
No, we use MRI.
And just a logistical question. I don't know if you know the answer to this because, I've had an MRI or two. I mean, it's pretty claustrophobic to go in there. Do you go head first for a rectal MRI or do you go feet first and your head stays out of it?
I have no idea the answer to that question.
Because it is, if you ever had one, it's pretty tight in there. It's pretty tight. So I wonder if you could keep the head out and just go face down, go feet first into the MRI. That's your next paper. We'll see you next year in Santa Fe.
Thank you.
David.
Next one up is validation of surgeons' venous thromboembolism risk assessment and use of prophylaxis in the perioperative patient, and will be presented by Dr. Emanero.
Yeah, Kevin Rodriguez Omaneno. Thank you. Yes, I'm a 4th year at St. Joseph Hospital in Denver, Colorado. Thanks for having me, guys. So determining the surgical patient VTE risk and prescribing chemical prophylaxis may occur by deliberate intent by the individual patient risk scoring, EMR guidance such as preoperative order sets, or by surgeon habitual practice. The aim of the study was to assess the congruence of surgeons ordering of preoperative and in-hospital and discharge VTE prophylaxis compared to the actual patient risk prophylaxis recommendation using the Caprini risk score model. Using our own hospital's NISQIP database and EMR, 127 general colorectal and oncologic surgical patients were chosen from April to June 2021, and they were reviewed for Caprini risk scoring and prophylaxis recommendation. This was compared to the actual perioperative and discharge chemical VTE prophylaxis received, and the outcome data included bleeding and VTE events within the last 30 days. Dr. Amy Walk of UCSF Fresno recently, just yesterday, kind of spoke a little bit about this. I'll be, and this is totally different study, but I'll be kind of speaking similar to that. There are no exclusion criteria. Just a brief review of the Caprini risk score VTE prophylaxis recommendations. We have a low risk patient, moderate risk patient, high risk patient, where we have different recommendations in the pre, peri, and post-operative chemical prophylaxis. And of course, a Caprini score greater than 9 is the highest risk score you can get, and you recommend 30 days chemical prophylaxis. Our results showed that within the low risk patient category, surgeons were prescribing upwards of 70% of preoperative chemical prophylaxis in the lowest risk category. In the moderate risk category, 74% of them were getting preoperative prophylaxis. And within these numbers, there were 4 of them that had active contraindications. And the highest risk category, 94% of them were getting preoperative and perioperative chemical prophylaxis. And the one patient, well, a couple of patients had active contraindications to them as well. However, we found most interestingly that the highest risk score patients, Caprini score greater than 9, only 10, where normally we would recommend postoperative VTE prophylaxis, only 10 out of the 29 patients were discharged with VTE prophylaxis. And these are patients that are not already on chronic anticoagulation. So upwards of 66% of them were discharged, where only 4 of them had active contraindications. So from these results, we found that perioperative chemical prophylaxis is being ordered appropriately in the moderate and high risk patient categories in our hospital. However, it appears that physicians, likely out of habitual practice, are not individual risk assessment, maybe driving the prophylaxis practice, especially in the low risk patient categories. There's an obvious need for improvement in discharge VTE prophylaxis in the highest risk patient category. We proposed using completely objective measures, obviously, 4 of them determining risk factors. Every patient has an age, BMI, length of surgery, and whether or not malignancy was present during the surgery. And having this act as another modified Caprini risk score for patients not already on chronic anticoagulation or without any contraindications. We personally, in our hospital, we will implement this risk assessment into the patient's discharge planning process, where literally they will click through these 4 questions. It'll take upwards of 10 seconds and see if they are a very high risk patient category, and act as another safeguard in preventing high risk patients from being discharged without appropriate VTE prophylaxis. Thanks for having me, guys.
As I read your abstract, you used almost exclusively some sort of heparin agent. Do you have any experience, or can you make any comment on switching to the newer oral agents for your long-term prophylaxis?
Yeah, for sure. Certainly, it's more out of, we found that it's more out of surgeon preference. Certainly not all of them, but the majority of them preferred Lovenox, and the acute surgical patient who, they're still worried about potential bleeding. So we found that to be at a more habitual practice.
Were these all Dr. Jason Johnson's patients that should have gone home and
All of
didn't?
them, yeah.
Which is why I knew his name noticeably absent as an author on the paper. So,
That's why he's here.
so well, first of all, I applaud you for your honesty. This is how we make change. You can't make a change in your clinical practice unless you're tracking the data. So there's an opportunity here, obviously. Did any of those patients that were deemed high risk and maybe should have gone home on something and didn't, did any of them have a VTE event?
Yeah, thanks for asking. No, none of them. With the Caprini risk score, greater than 9, I think it's about 10.7% of them have been found to have a VTE within 30 days postoperatively. So just by sheer percentage, that we should have had 2 to 3 patients who present with VTE. None of them presented with VTE.
Do you think with this growing body of literature and the medical legal environment we live in, that surgeons are putting themselves at risk, meaning that they could be liable
Absolutely.
for a VT event that occurred in this large body of literature for high-risk patients, and then you missed it on the discharge medication list?
Yeah, absolutely. And there's no roadblock in place for most hospitals. There's nothing, and it's certainly not something that should be done with every single patient that's discharged from a hospital. Go through 30 questions of Caprini risk scoring. That's not practical either. So that's why we found that it's surprising, upwards of 90% of our patients that would have been classified as a very high risk scoring met those criteria based on just 4 questions alone.
So you're going to prospectively, you're going to do the 4 moving forward?
Yeah.
Those 4 categories? All right. Well, we look forward to see what that data looks like next year in Santa Fe.
Yeah, I am too. Thanks.
Thank you so much. Thanks to all our presenters.
Is Ms. Spielman present?
I guess.
Session concluded.
Session's
Thank you
concluded.
very much.
Thank you all. Oh, okay.